Hi, everyone. Thanks so much for joining us. I'm Hillary Theakston, the Executive Director of Clarity, and I'm so glad that you've tuned into our Ovarian Cancer Online Symposium. This program has been created through a partnership with Clarity and the GOG Foundation, with a shared goal of supporting patients, caregivers, and advocates on the ovarian cancer journey. Our organizations are dedicated to improving ovarian cancer treatment through science. We want you to have access to the latest research and information so you can feel empowered and hopeful about treatment options and decisions. In these educational sessions, you'll be hearing from some of the most well-respected physicians and researchers in the field of gynecologic oncology. Through their work with GOG, they are on the cutting edge of the science of ovarian cancer, and they're helping to usher in the treatments that will become standard of care in the future. Our goal is to help you navigate the ovarian cancer experience on your own terms, with the information and support that is relevant to your unique situation. We know that anyone with an internet connection does not lack for information, but what's challenging these days is understanding if information is credible, if you can trust it, and if it's relevant given your particular situation. We are going to do our best to organize the content of these educational sessions so you can easily identify the information that's most useful to you. I also encourage you to opt in to follow-up emails from Clarity that will provide additional information and support based on your priorities and interests. I'd like to take a little time to introduce you to Clarity, and we'll welcome you to reach out if we can support you. Clarity's mission is to revolutionize the ovarian cancer experience, one person at a time. And I think it's important to understand a little bit how Clarity stands apart. In my years of working in the cancer advocacy space, I really haven't encountered another organization that provides the depth and breadth of support that we do. We provide in-depth scientific expertise to help with treatment decisions and professional support to manage the issues that arise during the ovarian cancer experience. The words of thanks that we receive from our patients and caregivers emphasize that our mission is having a real impact at a time when families are facing so many challenges through the ovarian cancer journey. I'm so proud of the expertise and compassion that our team members bring to conversations with participants every day. They're knowledgeable and trusted team members of our participant support team. When we talk about revolutionizing the ovarian cancer experience, we believe that really combining the professional expertise of science and counseling has a synergistic effect, which allows our participants to adapt to this experience and feel more prepared to meet new challenges on their own terms. So when we talk about a revolution in ovarian cancer, it relates both to treatment outcomes and to the experience. We want women to have the best possible treatment outcomes, which means longer survival and better quality of life. So we have to be experts in the latest science and research on ovarian cancer treatment. In this program, you'll hear from some Clarity experts about how we ensure people who come to us for help have access to information that can help them survive. We help people understand how genetics and tumor biology can impact treatment decisions, and we've developed some tools to make it easier to find clinical trials that might produce a better response with fewer side effects. When we talk about revolutionizing the ovarian cancer experience, that really relates to our counseling program. And I've heard many times that an ovarian cancer diagnosis really turns life upside down, and that the turmoil is as unique as the life that was upended. So just as we take into account tumor biology in our treatment education conversations, we also appreciate the importance of meeting people where they are and understanding their unique struggles with the ovarian cancer experience. Our counselors are trained to help with so many challenges that arise after a diagnosis and managing through this whole experience. They all understand how ovarian cancer may impact a person's life in different ways, both for the person who's diagnosed and for the people who care about them. So we really believe at Clarity that combining the professional expertise of science and data along with counseling has a synergistic effect, and that allows our participants to adapt to this experience and meet challenges on their own terms. You can imagine how our programs work together to help people stay engaged and hopeful throughout the journey, taking into account the whole person, physically, socially, mentally, and emotionally. This kind of in-depth professional experience makes a real difference. So please connect with us if you need support in any of these areas of your life. And now I'm so pleased to introduce you to Dr. Ramez Eskander. As a board-certified gynecologic oncologist, Dr. Eskander has a passion for improving outcomes for women with ovarian cancer, combined with extensive research experience. His expertise includes therapeutic procedures, including minimally invasive surgery, chemotherapy, novel drugs, and clinical trials. Dr. Eskander is an associate clinical professor in the Division of Gynecologic Oncology at the UC San Diego Moores Comprehensive Cancer Center, and is an active member in the experimental therapeutics team, as well as the Precision Immunotherapy Clinic, while leading the fellowship training program. Dr. Eskander joined Clearity as Chief Scientific and Medical Advisor in 2021, and he is an Associate Clinical Trial Advisor at GOG Partners as well. With all of these impressive credentials, I also want to mention that Ramez is a compassionate and generous person who's committed to the patients in his care today and to advancing improvements in ovarian cancer treatment for everyone who's facing this diagnosis. It's always a pleasure to work with someone who has deep scientific and clinical expertise, along with tremendous compassion and empathy for the human experience of a cancer diagnosis. Ramez, thank you so much for being with us today. And I think today we want to start with some of the basics of ovarian cancer before we get into more of the details in subsequent sessions. So maybe it makes sense to start with just the term ovarian cancer. It's commonly used to describe ovarian, fallopian tube, and primary peritoneal cancer. Can you help us understand what ovarian cancer is?
Of course. Well, firstly, let me begin by saying thank you, Hillary, for the kind and thoughtful introduction. I'm really fortunate to have an opportunity to be a part of both the GOG Foundation and GOG Partners, as well as Clarity, because the two organizations have a shared desire to improve outcomes for ovarian cancer patients. And it is an absolute pleasure to be able to participate in moving this field forward on different levels. So let's start there. Now, back to your question, really, what is ovarian cancer? Commonly, when patients are faced with diagnosis, it's hard to conceptualize what this means. And we talk about ovarian cancers, fallopian tube cancers, and primary peritoneal carcinoma. And these three words reflect different anatomic locations in which these cancers can arise. So the cell of origin can be in the ovary, can be in the fallopian tube, or it can be in the peritoneal cavity. And the peritoneal lining is almost like a clear wallpaper within the abdominal cavity that covers our abdominal wall and the intestine. So there could be divergent cells of origin, although most importantly, the management of ovarian, fallopian tube, or primary peritoneal cancer is analogous. And that's a really important point for patients to understand early in the context of a new diagnosis and initiation of therapy. And in the same breath, it's also important for us to realize that not all ovarian cancers are the same. So the word ovarian cancer or fallopian tube cancer, these are umbrella terms, and underneath these fall various histologies. The most common histology is high-grade serous ovarian cancer. These are epithelial types of ovarian cancer. But then we can also have low-grade serous, and these are completely distinct disease entities. Management can be quite divergent. Of course, there are some components in the therapy that they're shared, but there are important molecular differences. There's clear cell carcinoma of the ovary, yet independent of high-grade serous. There's mucinous carcinoma of the ovaries. And there are low-grade endometrioid histologies or high-grade endometrioid histologies. And although this seems nuanced, it's critical because understanding the type of ovarian cancer guides and informs the way we think about treatment and recommendations for systemic therapy.
Yeah, thank you, Ramez. Thanks for helping us get oriented to that. That's a good place to start. So, we hear often that hearing the term ovarian cancer can be pretty devastating and scary for patients and families. And while it's true that this is a very serious diagnosis, maybe we can take a little bit of time here at the outset to talk about some of the advances that have been made in treatment of this disease and how they'll continue to impact cancer outcomes over time.
Yeah, this is always exciting to share and to talk about. I've been fortunate enough to take care of gynecologic cancer patients now going on over almost 15 years in total. And when I think about this, the management of ovarian or fallopian tuber primary peritoneal cancer, it is exciting to see the progress that has been made, which is reflective of the work that's conducted in the clinical trial arena to try to identify effective treatment opportunities. But in parallel, it's also informative to our improved understanding of the molecular underpinnings of cancer. So let's start by first saying that when we look at ovarian cancer, the number of deaths from ovarian cancer is declining year over year. The number of new cases appears to be declining year over year, but the number of women alive with the disease is increasing. So what does that mean? We interpret that to mean that patients who are diagnosed are living longer with the disease, which suggests that after diagnosis, effective treatments are helping these patients live longer. And that's our shared goal. And in parallel, you may ask, well, why? What's causing this decline? And there are several theories, but one of the things that most pragmatically impacts us is genetic testing. We know that every newly diagnosed ovarian cancer patient should have genetic testing to evaluate for inherited susceptibilities to developing these cancers. Most commonly, we know about BRCA1 and BRCA2, but there are other genes, RAD51C, RAD51D, and this list goes on. So not only is it important to understand the type of ovarian cancer, but it's critically important to understand the relevance and the importance of genetic testing, because if a patient is diagnosed with an ovarian cancer and has genetic testing and is identified to be a carrier, for example, of a BRCA1 mutation that they inherited, then they can let their family members know, who can then be tested. And if they have yet to develop the disease, they can have risk-reducing surgery. And, one of the best ways to cure ovarian cancer is to prevent it in patients who have an inherited predisposition. So genetic testing is so incredibly important, and it also informs therapy, and we'll talk about that a little bit as well. And I will also say that the advances in ovarian cancer care have been multifaceted. So we talked about the importance of genetic testing informing, for example, the presence of a BRCA1 mutation, but there can also be mutations in the tumor that are not inherited from parents. And that's also relevant because it can inform therapeutic treatment strategies. We know that there's also an evolution in the molecular understanding of homologous recombination deficiency, or HRD, which is we think about it as a scar that is reflective of ineffective DNA damage repair. And we've identified that in patients who have an HRD positive, meaning a tumor that has a homologous recombination deficiency, they may be particularly responsive to a class of drugs called PARP inhibitors, when they could also be potentially combined with anti-angiogenic drugs, bevacizumab or Avastin. So we've identified both therapeutic targets, we've identified molecular aberrations that can inform treatment response, we've identified the relevance of germline mutations, both for the patient that was diagnosed and affected, but also with implications for their family members. And we've ushered in this new era of therapies, like I mentioned, PARP inhibitors, and for appropriately selected patients, potentially the combination of PARP inhibitors and bevacizumab. And this list of therapeutic interventions goes well beyond the ones that were mentioned, and I'm sure we'll get to it today as well.
Yeah. Well, it's great, Ramos. Thank you for laying that out. And I think what you're describing just generally is a really hopeful future and even present of more precision treatment in ovarian cancer, which there's still more to do. There's still we still need more treatments. We still need more diagnostics, but we're moving in a really encouraging direction. Are there other treatments, emergence of new treatments that you want to mention at this point that provide additional encouragement and hope, just in terms of improved options for folks?
Absolutely. And I think to your comment about better understanding of the disease, not long ago, we used to lump all ovarian cancers together. I call that disease homogeneity. We just put everyone together because we hadn't yet identified and understood the nuanced differences between the different ovarian cancer histologies and even within the same ovarian cancer histology. And now we've evolved into a world of molecular granularity, where in the context of molecular tumor testing, in the context of understanding what mutations may be present in the tumor, we've been able to identify effective treatments. So just a few of really what were groundbreaking discoveries in the ovarian cancer space. Number one, I will start by mentioning the efficacy of PARP inhibitors in the BRCA mutated patient population. Again, whether it was an inherited mutation or a mutation acquired in the tumor, that's called a somatic mutation, we have shown that utilization of PARP inhibitors as a maintenance in those newly diagnosed patients can result in significant improvements in survival. And quite frankly, using a word that we were reluctant to use previously, but curing some of these patients who present with advanced stage disease via the incorporation of PARP inhibitors. I mentioned previously the assay for homologous recombination deficiency. So about 20% of patients who have newly diagnosed epithelial ovarian cancer will have a BRCA mutation, either inherited or in the tumor. But we were able to expand that population by looking at ineffective DNA damage repair, this homologous recombination deficiency signal. And when we identify that genomic scar, we know that there's also increased susceptibility to the combination of a PARP inhibitor with bevacizumab or even PARP inhibitors alone. And that captures about 50% of newly diagnosed high-grade epithelial ovarian cancer patients, particularly high-grade serous. So we've gone from about 20% of the population with BRCA to now incorporating 50% of the population with meaningful improvements in progression-free survival and also provocative findings with improvements in overall survival. And I will say that there's also been a lot of excitement in general in the cancer arena around immunotherapy. I will humbly admit that we have yet to identify the right combination or identify necessarily the right patients that will benefit, especially newly diagnosed advanced stage ovarian cancer patients. But in the same breath, I will say that we have had biomarkers discovered in this space that have really improved outcomes. So for example, in clear cell ovarian cancer, a population of those patients may have mismatch repair deficiency or DMMR, meaning they have ineffective proofreading and DNA replication, and that creates errors that leads to mutations. And that also is reflected in something called the tumor mutational burden, a high number of mutations in the cancer. Both of these, either mismatch repair deficiency or high tumor mutational burden, have been correlated with a significant response to immunotherapy, and that's independent of where the cancer starts. We're not just talking about ovarian cancer. We can extend this to pancreatic cancer or breast cancer or lung cancer, this disease agnostic, I call it, biomarker. So there are some ovarian cancer patients who may benefit from immunotherapy when we look at these biomarkers. And then, of course, most recently, we had the FDA approval of a drug called mirvetuximab. Mirvetuximab is an antibody drug conjugate. It's an antibody that targets a receptor. In this case, it's folate receptor alpha. And that antibody is linked to what we call a payload or the drug that has efficacy. And the drug, first, a clinical trial called SORAYA, and then another clinical trial called Mirasol, showed the efficacy of mirvetuximab in patients with platinum-resistant recurrent ovarian cancer. And Dr. Kathleen Moore from the University of Oklahoma presented this exciting data at the ASCO annual meeting this last year, showing an improvement in both progression-free survival and overall survival in patients who have platinum-resistant recurrent ovarian cancer who are folate receptor alpha high. And then I will say in the same breath, and I know I can talk on and on about this, you could see the excitement, but in the same breath, we had the Destiny Pan-Tumor02 trial at ASCO as well, which looked at a different antibody drug conjugate, trastuzumab deruxtecan, which is actually used in breast cancer already. But this targets a surface receptor called HER2. And this study, it was a small study that enrolled cervical cancer, endometrial cancer, and ovarian cancer patients, among some other solid tumors. And the signal in an ovarian cancer population that was previously treated with was quite provocative and exciting for us to see. So we're eager to see how this moves forward into the therapeutic landscape. And I will just admit, this is a small peppering of therapeutic advancements in areas where we see an unmet need, and we're eager to see what new future clinical trials are going to bring. But again, this is just a testament to the fact that there are options, there are opportunities for our patients, and it's about knowledge, it's about education, it's about access to these opportunities.
Yeah. Thanks, Ramez. And we just wanted to give a little bit of an overview, and your excitement and hopefulness is so encouraging. And I think you're referring to information that is important for patients to be acquainted with. You're talking about the kinds of the histologies of different ovarian cancer tumors. You're talking about genetic mutations and genomic mutations in the tumor. So this is just another layer of data that is really important for patients to become familiar with, because they might have better treatment options. As a result, there could be drugs that are better suited for them. So since we're talking about treatment, maybe you can help us understand a little bit a typical treatment course for patients diagnosed with advanced stage ovarian cancer.
Thank you, Hillary. So when we think about a timeline, an ovarian cancer timeline, we think about the pivotal parts of treatment. At the time of diagnosis in a newly diagnosed advanced stage ovarian cancer patient, one of the very first decisions that has to be made after a biopsy confirms the diagnosis, if the disease is amenable to biopsy, is to make a decision between primary surgery versus neoadjuvant chemotherapy. And what neoadjuvant chemotherapy means is giving chemotherapy first, followed by surgery, and then additional chemotherapy. So again, that's our first decision, our first fork in the road is, do we do surgery first, or do we start with chemotherapy followed by surgery? And I will say that one of the most important points here is surgery is an incredibly important tool in the management and treatment of ovarian cancer, but it is hand-in-hand synergy between surgery and systemic treatment that improves outcomes. And why do I say that? Because it would be unfair of me to walk out of an operating room and say, I removed all of the cancer. What we can do as surgeons and say, we remove all the visible disease, what we can see is removed, but there's microscopic disease that remains. And in those cases, this is why it's so important to continue on systemic therapy, whether you have neoadjuvant chemotherapy or primary surgery that's successful. And the goal of surgery, and this is really important, the goal of surgery is to remove all the visible disease. So when we think about ovarian cancer surgery, we don't want to have a surgical intervention where we go in, remove a portion of tumor, and leave bulky cancer behind. If that's the circumstance, then we haven't really benefited our patients through the surgical intervention. And there are multiple factors that play into whether a patient is the right candidate for primary surgery or neoadjuvant chemotherapy. It is complex, it is multifactorial, and it is critical to have a conversation about this with a provider so that you understand, why am I having chemotherapy first? Or what makes me an excellent candidate for primary surgery? In parallel, whether you have primary surgery or neoadjuvant chemotherapy, this ties into the prior discussion about molecular testing, because you have tissue samples, and those tissue samples can be sent, and that molecular data can be used to inform maintenance treatment options. What's the utility? What might I expect the benefit to be as a patient of a maintenance treatment based on my molecular tumor testing? And we wish every patient had a molecular finding that would guide and inform maintenance, but there are a proportion of ovarian cancer patients where molecular testing doesn't inform patients. And sometimes we use this term biomarker negative for a patient whose molecular testing doesn't necessarily inform treatment opportunities. And so after this initial intervention, whether it's primary surgery followed by adjuvant chemotherapy or neoadjuvant chemotherapy, surgery, and additional chemotherapy, we usually incorporate maintenance treatment. And patients have a remission. They have a period of time in which the cancer hopefully doesn't come back. And the longer that interval of time is, the longer that primary remission is, the more likely a patient will respond to re-challenge with subsequent chemotherapy treatments. And I will say here, the concept of platinum sensitive and platinum resistant, many patients will have a conversation with a provider and say, well, the cancer came back in this window, it is platinum resistant, or the cancer came back in an alternate window, it is platinum sensitive. I will explain that we have used a cutoff of 6 months, meaning that if cancers come back within 6 months of completing frontline platinum-based chemotherapy, they are defined as platinum resistant, if more than 6 months platinum sensitive. But I will have a qualifier there, and I will say that over time, this definition has evolved a bit, meaning it is not black and white. There is some gray there. And there's been an understanding for us where we've actually incorporated terms such as no longer platinum appropriate or progressed on platinum therapy. But I will also have to be honest about the fact that in clinical trials, we're obligated to use a defined interval that can be replicated across institutions nationally and internationally. So for the purposes of clinical trials, that 6-month time point is usually definitionally required for both platinum sensitivity and resistance, as I alluded to previously. So there are nuances here, and these conversations are incredibly important. And if patients do develop a recurrence, whether it's platinum sensitive or platinum resistant, that guides treatment options, whether it's clinical trial or standard of care options. But what we know is usually the very first remission is the longest remission. And when ovarian cancer patients recur, they may recur in a platinum sensitive window, although with subsequent recurrences, if that interval shortens, they develop platinum resistant disease. And that's one of the reasons we're so passionate about drug discovery and clinical trials and helping patients identify appropriate clinical trials for which they may be eligible, because we understand that in the time course of the disease, patients evolve from newly diagnosed to platinum sensitive to platinum resistant, with some patients unfortunately having their first recurrence be in the platinum resistant setting. So I hope that contextualizes the time course of the disease a bit.
That helps. That helps so much, Ramesh. Thank you for that. So we've talked a lot about, I think, the basics of treatment and about the disease. And I'd love to ask a couple of questions about this experience. And we'll have some subsequent sessions that go into a little more detail by clinical situation. But if we can talk a little bit, just spend a little bit of time with what patients and their families experience after they hear those words. And I have heard so many times that an ovarian cancer diagnosis can come as a shock, and news of a recurrence can sometimes be even more devastating. Some patients have told me that their doctors tell them, don't Google it. And I have the sense that they want to shield families from inaccurate information or data that might be accurate, but might not be relevant given someone's unique situation. And then I also get the sense that the statistics about survival and recurrence can be stressful. At the same time, we want patients to have information that they need to make empowered decisions that are grounded in how they want to navigate through this experience. So, as with so many things on the ovarian cancer journey, I think it's a real balancing act between seeking information but not being too daunted by it. You know, you started our conversation with talking about statistics and how much hope we can find in some of those statistics. So maybe we can start with that a little bit, and maybe you can give some more context to how to interpret statistics that patients and caregivers might find online and in other places. So maybe we can start with a hopeful observation that 10-year survival statistics are by definition 10 years out of date. Yes. And a lot of the progress that you've spoken to already is not yet reflected in a 10-year survival statistic that someone might see today. But maybe you can give us a little bit of context in how patients can consume data and statistics and just have a little bit of context around that.
Such an important topic, so relevant to patients' lives, so relevant to our lives and as GYN oncologists who care for patients. The premise of don't Google it, it's not information is bad. It's access to the right information is critical. So to the point you made, Hillary, a moment ago, many of us at our fingertips can have access to information that is accurate, but we also have access to information that is inaccurate. And it's sometimes difficult to discern what's appropriate. Where is this information coming from? Is it reliable and can I trust it? So I work to try to offer patients access to websites where I believe that the information there is vetted and accurate, because information and empowering yourself as a patient or your family is critical. We all want to know more when we're faced with a difficult circumstance. I will also say that people are different, and the capacity for someone to absorb that information that's delivered via various platforms, digest it, understand it, varies quite a bit. And I have some patients that say, I don't want to look at any of it because I'm going to feel overwhelmed by that information. And I have other patients that are eager to get their hands on every piece of data. Now, to your comment about statistics, it's exactly right. So when you read a 5-year overall survival, that number is a general number that's based on populations of patients. Much of it is tumor board, or excuse me, cancer registry based data that's submitted. So does that percent reflect the patient that's sitting in front of me? That's the key question. And I will tell you my analogy. When I sit with patients that are newly diagnosed, I say, I am with you at the starting line of a marathon. We're just at the beginning, and we're going to run a marathon together. But I don't know what's going to happen at mile 2 or mile 5 or mile 10. But every milestone we get to is going to inform how things turn out at the end. So we take it one step at a time. You know, the clinical example of that is a patient who responds really well to frontline chemotherapy and has a successful surgery and has a biomarker, for example, and is on maintenance. Their outlook can be very different than a patient who may not respond at all to frontline chemotherapy, what we call a platinum refractory patient. So until we have data, until we have evidence of how the cancer is going to respond and how a patient's going to do, we speculate about these numbers, and that can cause a lot of unnecessary anxiety and fear. And so I am a proponent of education. I support my patients getting reliable education, but I also think it's imperative to allow patients to understand that each patient journey is different. And that ties into the comments you made at the very beginning. It's about meeting patients where they are. And each unique patient needs to have a unique conversation about their disease so that they can feel informed appropriately. And that's a collective job. That's our job. That's, you know, the resources that Clarity offers as a foundation. That is the family and loved ones asking questions. And hopefully in having a conversation such as that, we can create a more harmonized understanding of where patients are when they begin this journey, and then inform them as we progress.
Yeah, that's a great response. And you know, we hear oftentimes you're not a statistic, and so I think to be aware of the data and to be fully informed, but to appreciate that that this is your own course, this is your own journey, these are your decisions. You hit on the topic of family support and caregiving and having a support team. I'd love for you to just talk about, you alluded to the fact that patients are really different in how they approach this. And I would just love your observations about how you've seen families and caregivers come into support. Sometimes, you know, recovery from surgery can be physically exhausting. Chemotherapy has side effects. And so we've heard, of course, and I'm sure you've seen it, where caregivers are actually able to step in and do a bit of this research and help in coming up this learning curve. And would just love some of your perspectives and thoughts on that too.
Thank you, Hillary. Don't worry alone, ideally, is some phrase that I have heard from others and I appreciate. Another phrase that a dear patient of mine shared with me is don't borrow trouble. And what I think is relevant about both of these is number one, the diagnosis can be really difficult on patients, but also on families. In fact, there's a whole new area of investigation and research looking at caregiver support, because the diagnosis can be difficult on the patient, and the caregiver is there, the loved one, the family member, the friend who's trying to support that patient, but they themselves are scared, are worried, they don't know what to expect. Having a support system, having a team with the patient throughout this process is invaluable. Resources vary, of course. Different patients have different mechanisms of support, but it's also important to realize that those support mechanisms can exist outside of the traditionally considered structures, whether that's someone in the home, whether it's a friend, whether it's resources that we have at our cancer centers that can help families and patients navigate the course of treatment, or whether it's organizations such as the Clarity Foundation that has a program, the Steps Through Ovarian Cancer program, that can help educate patients and caregivers about what to expect so that patients don't feel alone, right? Many of the times, the feedback I get is, I'm scared. Is what I'm feeling normal? Am I overreacting? How can I get past this? And just speaking to someone else who's had a similar experience can give them significant peace to know, yeah, you're not alone. There are opportunities there. But certainly having an infrastructure around you as a patient is invaluable in navigating this path through treatment, of course, and hopefully into a remission.
Yeah, terrific. That is great advice and wonderful observations. In the time that we have left, I would just love to hit on a couple of topics because I think part of our purpose here is to help patients and caregivers get out in front of information and be proactive in the kinds of questions that they might be asking or items that they might be thinking about. And over the years, there are really three topics that I've observed are unfortunately addressed too late in the ovarian cancer journey. And you might have others that you can feel free to add. But just to get started, the ones that I'd like to talk about are palliative care, clinical trials, and second opinions. And I think that if these topics were presented and considered earlier in the patient journey, it would be such a great benefit to patients and families. And so I want our listeners to be prepared to raise these issues proactively in a time where they can get the most benefit. So maybe we can start with palliative care, which often gets confused with hospice or end-of-life care, which it absolutely is not. Can you start us off just by helping us understand what palliative care is and why earlier is better when it comes to engaging with this topic?
I think of the three things you mentioned as like three pillars to a support tool for a patient as they in the treatment course for their ovarian cancer. Palliative care is not, I will repeat, palliative care is not hospice care. It is not end-of-life care. It is supportive care for symptom management. It is incredibly important. We actually use palliative care from the start of treatment if we need to. And I do work to educate patients about why is symptom management relevant? Well, symptom management is important because good symptom management improves quality of life. Good symptom management helps ensure that patients can stay on treatment, meaning receive the chemotherapies that are effective in managing the disease. Good symptom management helps ensure that patients, when they're in remission, feel well so that they can enjoy their lives. I say going through the process of a big surgery and chemotherapy and maintenance treatment, the goal of those things is to be able to live your life and enjoy your life, not essentially feel like either I have miserable treatment-related side effects or I have this terrible anxiety and weight that weighs me down and prevents me from living my life. The goal is to be able to have a good quality of life beyond that. And so palliative care is a programmatic initiative that is multifaceted and has experts who are trained in this component of treatment that prioritizes symptom management so patients can have an excellent quality of life while they're on treatment and after they complete therapy. And if you think about it that way, who wouldn't want palliative care?
Yeah.
Who wouldn't say, sign me up. I want to feel good when I'm on chemo. I want to feel good when I'm done with chemotherapy. There is no downside to this. And that's how I feel about palliative care. And, many institutions, including our institution at UCSD, are fortunate enough to have palliative care programs that are geared towards exactly this.
Yeah.
Now, the
Well,
second,
that's a great, yeah, tip.
sorry, Hillary.
No, I was just going to say, I think we hear it so frequently. And so I just wanted to underline how important it is and how much benefit it can have. And I feel like we support participants throughout the country, and we hear such variances in whether this is even offered, whether it's even mentioned. And so I think it's something that that patients and caregivers can be proactive and knowledgeable about, so that you can address that early in the experience for maximum benefit, to your point.
Yes, agree completely.
Yeah.
And your second point about clinical trials. Of course, I am a clinical trialist. I love clinical trials. I value the importance of clinical trials. But it is never, never too early to talk about clinical trials. Why? Because there are times when we have frontline clinical trials, meaning we have clinical trials that are available for patients at diagnosis. And sometimes patients have to be enrolled right after surgery. So when a patient is diagnosed with ovarian cancer, that term clinical trial should be front of mind at diagnosis. And of course, sometimes patients will be eligible or ineligible. That can be quite a complex and nuanced algorithm to figure out. But the only way to know that is to see someone and talk about the opportunity for clinical trials. Or there may not be a clinical trial available in that setting of the disease. There may be a period of time where we don't have a clinical trial for a newly diagnosed advanced stage ovarian cancer patient. But I will say, and I emphasize the fact that asking and receiving an answer and then making a decision based on that answer, in my mind, is exponentially better than not being able to ask that question or not knowing to ask that question and having an opportunity pass you by. Yeah. So and why are we so passionate about clinical trials? We're passionate because we know that standard of care options are not as effective as we need them to be. So clinical trials are critically relevant so that we can try to identify effective treatments. And if we do identify them, then these trial drugs become the standard of care in the future. The analogy we used earlier is mirvetuximab's recent approval in ovarian cancer. Not long ago, that was a drug that was only studied in the clinical trial space. And again, this to me highlights the service. I think about GOG Foundation and the GOG Partners clinical trial portfolio, trying to make sure that we have drugs that are being studied in these spaces to improve outcomes. And I think about the Clarity and our clinical trial finder that was developed that helps patients navigate. And it's not a generic clinical trial finder. This is a very specific, thought out opportunity where there's also a human being on the other side of that phone talking to you, trying to figure out if you're eligible. So really critically important, never too early to bring up.
Yeah. Such a great point. These are the drugs of the future. These are how we're going to be bringing new, more effective treatments to this disease. And it's not uncomplicated. And so having someone there who can help talk you through it, I think is really important. And that leads us a little bit to this third point, finishing up, talking about second opinions. There's no doubt that getting a second opinion is best cancer care. But I've heard sometimes it's intimidating for patients to pursue this option. They might feel self-conscious about discussing it with their primary oncologist or hesitant about how to move forward. So I think it would help our listeners to hear from you about how you think about second opinions, whether you're encouraging your own patients to seek a second opinion or whether you're giving a second opinion yourself.
Yeah. Oh, this is it's sensitive to me. Why? Because it breaks my heart when patients are almost asking permission to get a second opinion.
Yeah.
And so when I'm sitting in the office and I have a patient across from me and I get the impression that they're wondering if it's okay, I will immediately say to them, absolutely. And actually for me, I've worked to be more proactive about saying it from the beginning so that I can remove some of that pressure from patients and their families. Absolutely, as you mentioned, second opinions should be part of cancer care. I very frequently recommend for my patients to see colleagues for second opinions. It ties into the clinical trial comment I made a moment ago. No institution has every clinical trial open all the time. But when we have colleagues and I can refer a patient to a colleague for a second opinion who may have a trial for that patient, I'm helping that patient explore their options and potentially have access to a drug that could improve their cancer outcomes. And so I want to empower patients. I will say this, I wish I could yell it from the mountaintop. I want to empower patients to ask for second opinions, seek second opinions. Me as a physician, I should never react in a way that discourages my patient from getting a second opinion. I'll be quite honest. If I did ever react like that, or if a provider did, I would see that as a warning sign to some degree. Second opinion should be welcomed. We collaborate a lot. We have colleagues that work at other institutions who are also experts in the gynecologic cancer space. And a second opinion may validate the treatment that you're receiving. A second opinion may provide you with additional information, knowledge that doesn't necessarily change what you're receiving, but at least gives you greater context. A second opinion may afford you an opportunity to enroll on a clinical trial that's available at a different institution and not your own, or in some cases, a second opinion can change your treatment course altogether for disease. So there are different possible outcomes for a second opinion, and I will say that in my mind, patients should never feel guilty to ask their provider about a second opinion. Getting a second opinion can feel overwhelming, but I will tell you that thankfully in the healthcare world, I believe that we've gotten better at making it more feasible for second opinions, including at our institution and via resources in Clarity as a second opinion resource to help patients find providers that could theoretically help. So this, in my mind, it's an absolute pivotal part of cancer care.
Yeah. Well, thanks for helping to diffuse that. And I think it's helpful to hear from a physician, right? Because if the topic has never come up and a patient is worried that they might offend their physician, and that's a delicate relationship. That's an important relationship for the patient. And it's understandable why they wouldn't want to cause offense or ruffle feathers. But it's wonderful to hear from you, Ramez, and your perspective from the physician, from being on the other side of that conversation about how important you think this is. This is the patient's life. These are their decisions that they're making about their treatment. And we started this call with a quick summary of all of the exciting advances, new treatments, new clinical trial results. It's a lot to stay on top of, right? And so to have other voices, and like you said, even if it's just reassurance that you're not missing anything, this is what I would have recommended too. We hear from patients that can be tremendously reassuring. So thank you for addressing that. And we are just about out of time. The time has flown by. Thank you for all of the great observations and information and resources. I just want to end a little bit with where we started, which was there's so much information that's available to patients, and it's so important to make sure that you can trust the source of the information and the education that you're seeking and that you're accessing. So we will continue to make resources and information available through this webcast series. We hope that you share it with other patients. We'll have follow-up from Clarity and from the GOG Foundation with website resources and other information that can be helpful to you along your journey. So I just want to say, Ramez, thank you so much for your time today. Thank you for sharing information in such a compassionate and accessible way. And we'll look forward to having more of these conversations through this series in the future. Thank you so much.
Thank you, Hillary, and thank you to Clarity, and thank you to the GOG Foundation, both of whom are doing amazing work in the ovarian cancer space.